Pulmonary regurgitation, PR. Definition, etiology, pathophysiology, clinical, diagnosis, management. Pulmonary regurgitation, PR, equals backward flow of blood from the pulmonary artery to right ventricle during diastole. Usually secondary to other cardiac diseases, rarely isolated. Often well tolerated unless severe or with pulmonary hypertension. Etiology. 1. Pulmonary hypertension, most common acquired cause. Functional PR due to annular dilation. 2. Congenital causes. Repaired tetralogy of Fallot, post-surgical PR very common. Congenital absence or dysplasia of pulmonary valve. 3. Other acquired causes. Infective endocarditis. Rheumatic heart disease, rare. Carcinoid syndrome. Iatrogenic, after balloon valvotomy or surgical intervention. Pathophysiology. Incompetent pulmonary valve leads to diastolic backflow into RV, leads to RV volume overload, then RV dilatation and dysfunction. Chronic PR leads to right heart failure. With pulmonary hypertension, high pressure PR, Graham-Steele murmur. Hemodynamics. Normally the pulmonary valve prevents diastolic backflow. In pulmonary regurgitation the valve is incompetent and retrograde diastolic flow occurs into the right ventricle. This results in right ventricular volume overload, dilatation, and dysfunction. The severity of regurgitation depends on the diastolic pressure gradient between the pulmonary artery and the right ventricle and the size of the regurgitant orifice. High-pressure pulmonary regurgitation occurs in pulmonary hypertension and produces the Graham-Steele murmur. Low-pressure pulmonary regurgitation occurs in conditions such as annular dilatation or post-surgical states. Clinical features. Symptoms. Often asymptomatic if mild. Fatigue, exertional dyspnea. Palpitations. Symptoms of right-sided heart failure, edema, ascites, hepatomegaly, if severe. Signs. Early diastolic murmur, high-pitched, best at left upper sternal border. Graham-Steele murmur, high-pitched, decrescendo murmur due to PR from pulmonary hypertension. Signs of RV enlargement, parasternal heave, wide splitting of S2. Differential diagnosis of early diastolic murmurs. Aortic regurgitation, left sternal border, associated with bounding pulse. PR, Graham-Steele, pulmonary area, increased with inspiration. Rare congenital murmurs, example, truncus arteriosus. Investigations. ECG, RV hypertrophy, right axis deviation. Chest X-ray, RV enlargement, prominent pulmonary artery segment. Echocardiography, gold standard color Doppler shows regurgitant jet. RV dilatation and dysfunction. Estimate pulmonary artery pressures. MRI, gold standard for quantifying regurgitant fraction, RV size and function, especially in repaired TOF. Cardiac catheterization, rarely needed. Complications. Progressive RV dilatation and failure. Atrial arrhythmias, AF, flutter. Sudden cardiac death, especially post-TOF repair with severe PR. Right-sided heart failure complications, congestive hepatopathy, ascites. Management. Medical. Often not required if mild. Diuretics for right heart failure. Pulmonary vasodilators for pulmonary hypertension, if present. Surgical/interventional. Pulmonary valve replacement, bioprosthetic or homograft, for severe symptomatic PR with RV dysfunction. Transcatheter pulmonary valve implantation, TPVI preferred in post-TOF repair patients. Indications for surgery, severe PR plus symptoms. Severe PR plus RV dysfunction or dilatation, even if asymptomatic. Prognosis. Mild PR, excellent prognosis. Severe PR, risk of RV failure, arrhythmias, sudden death, especially in congenital heart disease survivors. Early valve replacement in selected patients improves survival and quality of life.